Well, good morning and welcome to Grand Rounds. It is my distinct pleasure this morning to introduce Professor Ira Lesser to deliver today's Grand Rounds lecture. Ira is a distinguished professor of psychiatry, which is the highest rank one can achieve in the University of California, as well as the chair of the Department of Psychiatry at Harbor UCLA Medical Center. Ira is a native of the East Coast, but after completing his undergraduate degree at Buffalo and his medical school at Pittsburgh, he had the wisdom to come to California, where he has built a career at Harbor UCLA. He was an intern at Harbor UCLA a couple of years ago. And he has had a variety of administrative roles over the years, including head of adult psychiatry and for 17 years, director of the psychiatry residency training program at Harbor, which he built into a nationally sought after and highly visible psychiatry residency program. He has been an advisor on a national level on residency education and has been an enormous resource in education here at UCLA. The recipient of numerous teaching awards, including 3 times the best residency educator at Harbor UCLA, as well as the Distinguished Educator Award from our department. Since 2005, Ira has been the chair of psychiatry at Harbor UCLA, which he probably won't like my saying makes him the longest serving chair at Harbor.
And the oldest. And the oldest.
But he's still a very young man. It was very, as part of this exercise, one goes over a colleague's CV, and it was really a treat to read Ira's CV. He's author of more than 140 publications, covering a whole range of topics. But there are 5 themes that he's managed to really carry through his career. One is on geriatrics. He's done a tremendous amount with geriatric depression and dementia. Obviously, public sector psychiatry as well, and the care for those who are less fortunate. And as related to that, he's done an impressive amount of work on ethnicity and the role of ethnicity in mental health. Everything ranging from the genetics of response to pharmacologic agents to health insurance and outcomes of treatment for depression. So it's been a very broad portfolio. He has done quite a bit of work in anxiety disorders, and he also has done a lot of work on the topic of today's Grand Rounds, which is suicide. Ira has written extensively on different facets of suicide in the elderly, those with medical illness. He's had a particular focus on physicians and physician well-being, having served a number of committees looking at issues surrounding physician well-being. He's been on the clinical advisory board of the American Federation for Suicide Prevention, and as well has been PI, principal investigator on a National Institute of Mental Health grant to study suicide assessment methodology. So he's extraordinarily well qualified to talk with us today, give us an update on suicide, and to talk to us about not just the research, but the human aspects of this terrible problem. So it is my pleasure now to turn things over to Professor Ira Lesser.
Thank you, Andy. That was a lovely introduction. Usually my mother helps write the introductions to these. But in this case, Andy's youngest son is a 4th-year medical student, and he's completing his rotation at Harbor UCLA in our psychiatric emergency room tomorrow, I think, or today. So I'm sure that Michael has said his evaluation depends on Andy's introduction of me this morning, so I'll tell Michael. Well, it's great to be here. A lot of friends in the audience, and people in the audience who know equally as much about suicide as I do, and in certain areas of suicide, much more than I do. So for those of you who I'm talking with, absolutely, if you have things to add while I'm talking, that's fine. We'll have questions at the end, but if you have something burning before then, please feel free to talk about it. I have nothing really to disclose. And let me tell you what I'm going to talk about and what I'm not going to talk about. And before I do that, let me just put it in context. So there's been a lot of public attention to suicide, a lot of research in suicide, and suicide remains an enormous public health problem. So if you look at sort of 8 or 10 of the top reasons that people die, suicide is among them, and I'll show you. And for virtually all of those others, the suicide rate over the last decade has decreased. Suicide rate for cancer has decreased, suicide rate for cardiovascular disease has decreased, suicide rate for HIV has decreased, and the suicide rate the death rate, and the rate of suicide has increased. It's the only one in the top 5 where the rate has increased. And that really makes us think about what we're not doing very well. So that's just sort of the context of this. So I want to talk a little bit about the epidemiology, some of the risk factors, and how to do a risk assessment, and what are the obstacles to doing a risk assessment. And then focus somewhat on the psychological view. We tend to lump suicide together, or people who attempt suicide, but there really is a really wide variety of phenotypes, if you will, for why people make an attempt. And without thinking about that, I think we lose an ability to make some interventions. And finally, we'll talk about management. I won't cover, because of time, the neurobiology, although there is a burgeoning neurobiology, looking at neurotransmitters, looking at neuroimaging, biomarkers. None of them are useful at the present time. People are studying the genetics of suicide. And like studies of the genetics of other major complex diseases, depression, schizophrenia, very little has really held up in replicated studies. There's a lot of interest in epigenetic phenomena, because it seems to be an increase in suicide among adults who were maltreated as children, child sexual abuse, and whether that has changed neurotransmitters, the HPA axis, unclear. And I'm not really going to talk about the sociological aspect. So I'm curious. I'd like to see a show of hands of people who have had suicide touch their lives in some way. Could be professional, could be personal, just people who have had an experience with suicide. So just look around, okay? It looks like maybe 80% of people, okay? How many people have had suicide related to their work, either their own patients or a team that you were on were suicide? Okay, so it's again about 50%. Again, so this just shows that this is an unbelievably, exceedingly common phenomenon, particularly amongst people that we see. So where do you think the highest rate of suicide in the country occurs where? What site? Think north of here. Think water. Think a bridge. Come on, guys. All right, the Golden Gate Bridge. I want to show you a quick video. And my son's in the audience, and he helped me do this because, as Andy and Michael said, I have no capacity to embed a video in any of these things. Okay, so let's just watch this. It's a 4 or 5 minute video.
We have lost far too many lives. We have lost traveling far too many lives. Traveling the path.
Since 1937, over 2,000 people
Since
have died
1937,
over 2,000 people have died at the
alive
Golden Gate Bridge.
every single day.
I feel lucky to be alive every single day. Of the thousands that have died off the Golden Gate Bridge, I am of the 1% who have survived. So I was born on drugs and premature. And then I bounced around from home to home. Nobody wanted to keep me because I was sick. And I got lucky. I landed in the home of Patrick and Deborah Hines. I had a great childhood. I thought, growing up, that everything's gonna be great. And then at 17, it all came crashing down. If you can imagine feeling that everyone around you is out to get you, trying to hurt you, and trying to kill you. And you believe that to be the truth. From the extreme paranoia, I exhibited symptoms of mania. From the mania came the hallucinations, both auditory and visual. And so with that and the bipolar disorder, I just was spiraling out of control. I vividly remember writing my suicide note. People don't get it. Like, I thought I was a burden to everyone who loved me, because that's what my brain told me, because that's how powerful your brain is. I got off the bus. I walked slowly down the walkway of the Golden Gate Bridge. You know, people rode by me, drove by me, walked by me, and a woman approached me, and she said, "Will you take my picture?" She said thanks, and she walked away. It was that moment I just said, nobody cares. The reality was that everybody cared. I just couldn't see it. I ran forward, and using my two hands, I catapulted myself into free fall. What I'm about to say is the exact same thing that 19 Golden Gate Bridge jump survivors have also said. The millisecond my hands left the rail, it was an instant regret. And I remember thinking, no one's gonna know that I didn't want to die. In 4 seconds I fell 75 miles an hour, 25 stories, and I hit the water. I was in the most physical pain I had ever experienced, I have ever experienced. The Coast Guard was amazing. He was just so freaked out that I was alive that he just dove in and brought me on board. The guy said, "Do you know how many people we pull out of this water that are already dead?" And I said, "No, and I don't want to know." The guy put his hand on my forehead, said, "Kid, you're a miracle." My father took one step into the hospital room, and I looked up at him and I said, "Dad, I'm sorry." And he said, "No, Kevin, I'm sorry." And if you think about it, both of our immediate reactions were guilt. Guilt that didn't belong to either of us. And even though I didn't die, I caused people a great deal of grief and pain. Just the day of my attempt still sits within them today. I asked my father if he still feared my death by suicide. He said every time the phone goes off, his first inclination is Kevin alive. I had that impact on my dad. So after the jump, the road to recovery was pretty long. I had 7 psych ward stays in the next 11 years. I still have all the symptoms I ever had. Mania, depression, psychosis, hallucinations, all that's still there. I just know how to cope with it and I know how to beat it. I built a support network over these years of treatment so that I wouldn't be fighting this alone. So like, it's okay not to be okay. It's not okay not to ask for someone to back you up. To the families who live with the loss or losses of loved ones, they didn't do that to hurt you or destroy your life. They took their lives because they were struggling and in a great deal of emotional and mental pain. Suicide, mental illness, and addiction are the only diseases that we blame the person for perpetually. But people die from suicide just like they die from any other organ diseased. Today, no matter the pain I'm in, no matter the struggles I experience, I do believe that life is the greatest gift we've ever been given. And if you're suffering mentally, don't wait like I did, sitting in denial for so long. Because recovery happens. I'm living proof.
You know how to get back to the other thing now. Okay, so this really, this exemplifies a number of the things I'm going to talk about in this section on psychological aspects. Okay, so let's go on. Now, this is a quote. The word says psychiatrist because that's what Robert Simon wrote. He's the co-editor of the APA book on suicide assessment, in which Dr. Michael Gitlin has a chapter, which we'll talk about in a little bit. 2 kinds of psychiatrists, those who will have patients who commit suicide and those who will. Really putting it into perspective that the people we deal with, particularly inpatient and serious mental illness, will die, and it'll affect many of us. So why do we care about this? Well, let me give you a number of statistics. So in 2016, there were close to 1 million suicides in the world in 1 year. If you do the math, that's every 40 seconds somebody takes their life. Worldwide, it's the second leading cause of death in young people, people age 15 to 29. And in the United States, it's the third leading cause of death for young people, and the 8th or 9th or 10th, depending on the statistics, for adults. And in addition to people who make a completed suicide, infinitely more make a suicide attempt. So that's estimates over 1 million people in the US will make an attempt that requires some mental health or health intervention. And as I said earlier, despite everything, despite research, despite public awareness, the suicide rate in the last 15 years has increased by over 30%. Increased over 30%. There's a lot of speculation. Suicide rates tend to increase when economic downturns occur. There's other things. We'll talk a little bit about teens and the stress that teens are under. But in general, this is an astonishing statistic. And there's no end of this in sight. The curve continues to rise. And the rise was most for women and young girls, where their increase was, I think, in the 30 or 50%, and for men, it was in the 30s. And as the last bullet shows, the rate is considerably higher in veterans, both combat-related veterans and veterans who did not see combat. So this is a very busy slide. You don't have to worry about it. But really, this shows ages across the top, with young, 10 to 14, and then the last is all ages, and just shows where suicide fits in terms of deaths per year, age, for the number of people in that age group. So you see, it's the third leading cause for young people, early teens, second for young people, age 15 to 34, and then it goes down. And for all ages, it's the 10th leading cause of death. How do people kill themselves? Well, the CDC has data that almost 60%, 55, 56 of men use firearms, which we'll talk about in a little bit. And I'm not going to do an editorial, but it's sort of a no-brainer if you think about that. We'll talk about that a little bit. Suffocation is related to hanging or carbon monoxide poisoning. For women, poisoning is the number one, firearms a little bit less, but that also is changing as the rate for women increases. They're tending to use more violent means. Lots of people have suicidal ideation. This is a hard thing to research, but in a number of studies, it's been estimated that maybe 13% of people have suicidal ideation. But even though suicide, I've said it's 40,000 or 45,000 in the US, that's a relatively small number given the number of people who have suicidal ideation. So the vast majority of people with suicidal ideation do not go on to make a completed suicide. Most of them don't go on to make any suicide attempt. They just have thoughts about it. If you flip it around, many people who have completed suicide, there was no inkling that they had suicidal ideation. Now, they may have and not shared it, so it's very hard to know what role suicidal ideation has in this. But what is clear is every suicide attempt that is made increases the likelihood of a future completed suicide. So in terms of taking a history, that's a very important variable to think about. And then finally, why should we care about this? Numbers are numbers, but you got a hint of that in the video. Untold amount of pain and suffering for survivors. This includes family and friends, it includes communities, and includes care providers, teams, therapists. I alluded to a chapter that Mike Gitlin has in the suicide. Mike has written what I think is the absolute best writing on the reactions of a therapist to suicide. We've had a couple of suicides amongst residents and colleagues at Harbor, as I'm sure you have here, and that is always an article that I give to them because it humanizes and universalizes the kind of reaction that people have. So if you want, Jonathan, if you want another talk, you can ask Michael to give that talk. It's an incredibly moving talk in addition to the chapter that I alluded to. Okay, here's another question for you guys. What's the answer? Okay, let's do it again since only about 50% of people answered. We'll try it again. This is not hard. It's not a trick question. Well, actually, it's a partly trick question. How many people think suicide is predictable? Okay, so maybe 10%. And not predictable? So the majority. Okay, and I think that really is the consensus. But predictability comes in two different forms. And what I'll show you a little bit, the ability to predict in the short term is abysmal. Abysmal. The ability to predict in the longer term is not abysmal, but it's better than in the short term. But it's still not where we would like it to be. So these are the sort of traditional risk factors that I think everybody knows about. Some are static: age, ethnicity. Some are related to psychiatric disorder. So you can see this. I'm going to pick a few of them and just sort of go in detail, because I don't want to spend the whole time talking about risk factors. So age is clearly related. And as you see here, this is from 2008 to 2017. The curve continues to rise, with the steepest rise amongst young people. Still, the group that is the most at risk tend to be, number one, older, and I mean older men over the age of 85, and that tends to be older white men. Has the highest rate given their representation of the population. Next are middle-aged men and women, and then there's an increasing amount of, and as you see, 2017, the curves are getting closer, meaning that young people, it's the rise in young people, it's not the drop in suicide amongst older people. That's very, very concerning. Now, this is, again, a little bit confusing, but this shows both age and male-female ratios. So you can see amongst the old, over 65, it's much higher, the ratio is much higher men to women than if you look at teenagers, where the rate is less than, it may be 50% more, whereas in the older people, it's almost 500% more. So that younger women, again, it's younger women who are making more attempts, and that's a group that intervention needs to be geared to. In terms of ethnicity, these data are also from the CDC. American Indian, American Natives have the highest rate, and that's been true for many, many years, followed by Caucasians. And then you could see the rest. Again, even within each of these, there are interesting differences, cultural differences. In African American communities, suicide is almost unheard of in women over the age of 40. It has to do with men have already either been incarcerated or been killed, so that the culture is such that it's much more women-centric. In Asian Americans, as well as in Asia, the number of older Asian American women who kill themselves is actually equal to Asian American men of those ages. So within each cultural group, there's interesting kinds of findings. And this shows the teenage rate. So teen suicide is soaring. There's this differentiated white and black, and you can just see that the rates are increasing. Very, very sobering. Along with this are some data that was reviewed in the Journal of Pediatrics, where they looked at quite a number of children's hospitals, almost 50 children's hospitals. And again, between 2008 and 2015, the number of children or adolescents brought in for suicide attempts almost doubled. So we're not just talking about ideation that doesn't have an impact. We're talking about actual medical and psychiatric morbidity. The increases were seen amongst all groups. It was somewhat increased more in women, as I said, than in young girls as opposed to boys. And there's no surprise it's much higher during the school year. Now go to the other end of the spectrum for older adults. So older adults today account for, and I mean older adults in this study is over the age of 65. We account for, we, some of us are we, account for 12% of the population, but make about 18% of suicides. So you could see that the relative risk for an older adult is much higher than it is for someone else. Why is that true? Well, older adults also have a narrower ratio between attempts and completed suicides because there are several factors. One, they tend to plan out suicides more carefully. They use more lethal means. They may be less resilient to bounce back. And there are differences. The psychiatric disorders of older adults who kill themselves tend to be predominantly depression, 80 to 90%, whereas the psychiatric disorders of younger people are much more mixed. You have depression, bipolar disorder, but you have schizophrenia, you have substance abuse, you have much more impulsive kind of suicide attempts and completed suicide in young people compared to older people. Something that I don't think we pay enough attention to, and I mean we had a case about 6 months ago of a young man who was hospitalized for 10 days, family was involved. We did what I thought was a very excellent job of his inpatient care. Made a plan, he had an appointment with his family at a mental health clinic 3 days post-hospitalization, which again is almost unheard of, and 2 days after hospitalization killed himself with no warning. And this highlights what this study, which is really quite recent, it's a JAMA psychiatry study with and it can do, much more substantive social factors that can worsen a crisis listed on here. And this is just a few of them. You could all think of many, many more. But probably something really, really important, and I'll get back to this in a little bit, is the relationship issues, the feeling of rejection, the feeling like the gentleman on the YouTube video talked about, feeling of burdensome. And so many suicide attempts, the immediate catalyst is some kind of rupture in an affective bond. It doesn't have to be a breakup, but it's just something that they feel has broken a bond of something. So there's a lot of other things on here, certainly worsening of psychiatric condition, worsening of depression, bipolar disorder, worsening of psychosis, et cetera. Many psychiatric diagnoses are related to suicide. It's estimated that 90% of people who make a completed suicide have a bona fide psychiatric diagnosis. Clearly, the biggies here are major depression and bipolar disorder in young people, younger people, schizophrenia. PTSD has had an increase in the number of suicides. Alcohol, substance abuse, either on their own or admixed with other disorders. And then there's personality disorders as well. Again, I'm not going to go into any of these in real detail. And then finally, in terms of illness, thinking about medical illness. There's an increased suicide rate amongst people with chronic medical disease, particularly pain states, which are very difficult. Huntington's disease, a neurologic disease with psychiatric manifestations, has one of the highest suicide rates of any disorder. Other disorders that affect frontal circuits, if you will, Parkinson's disease, frontotemporal dementia, also have higher suicide rates. So there may be something in a neurobiological aspect about frontal circuits that feeds into this. Okay, additionally, although less useful are the genetic or biological effects, suicide does occur in families. The contribution of genetics versus family or learned behavior is hard to tease out. Childhood trauma, as I mentioned earlier. But a big thing is the access to firearms. So almost 60% of men kill themselves by firearms, 35% of women. Countries which have made more stringent firearm regulations have clearly less suicide rates than we do. States that have more restrictive firearm laws have lower suicide rates than states that don't enact that. And I'll show you a slide in a second that suicide, many people commit suicide because something is right there allowing them to do it in a sense. Okay? So if you have a gun, you might use it. If you don't have a gun, it may buy you enough time that the event doesn't occur. Okay? There are many more suicides now than there are homicides in this country. And when everybody talks about gun control, they talk about homicides. Suicides outnumber homicides by 2 to 1. So you would save that many people. But that's editorial. Cognitive features, there's some interesting stuff on concussions, TBI related to suicide. This can occur in delirium when people have a confusional state. Finally, the whole notion of aggression and impulsivity has been linked to suicide, possibly through a link to serotonin. People who are risk takers have low serotonin. There were studies 10, 15 years ago looking at people who committed violent suicides, and they looked at suicide receptors in the brain, and there seemed to be some correlation between the violence of a suicide attempt and serotonin. But this is sort of speculative and again, not useful for the moment. On the other hand, there are protective factors. And if you're going to do an evaluation of a suicide risk assessment, one needs to consider protective factors. Religiosity, community support, children in the home, although that can go both ways, positive coping, a good therapeutic relationship, et cetera. Okay, just real briefly, suicides do occur in hospital settings. Tom Strauss and I have talked about this because it's a major concern. It used to be thought, and the Joint Commission had put forth a number of 1,000 a year, which is really a very high number. More recently, they've re-estimated it to a much smaller number. But the Joint Commission, we had a Joint Commission visit 3 weeks ago, mid-cycle. They spent a day specifically on suicide, on our documentation about suicide, on our ligature risks, whatever. So I talked to Tom, and we're going to have a meeting about this, because Joint Commission is made suicide one of their major patient safety goals. So for people who work in inpatient, it's very important. And in hospitals, there are probably two different profiles. Most suicides occur in psychiatric hospitals. Some occur in medical hospitals. The ones in psychiatric hospitals tend to be younger people admitted, prior suicide attempts, perhaps psychotic. In the hospital setting, tends to be older people, maybe some confusion, maybe some delirium, maybe somebody who has just gotten news of a chronic illness, maybe somebody who's on opiates, et cetera. So there's two different populations. Okay, so now how do you put it all together? So there's different ways of talking about it. One is called a suicide risk assessment. There has never been data that shows that a particular constellation of these things we talked about is useful in predicting immediate suicide. Doesn't mean we shouldn't do it, but that's the state of the art. There are a lot of suicide scales now. The Columbia Suicide Severity Scale, the safety thing is something the APA does. That's a start. The problem is if people do it, they think that's a finish. The Joint Commission, again, requires emergency rooms that see patients who have behavioral health issues to do a validated scale. Validated scale, meaning the Columbia or whatever. That's what they care about. That's not a full assessment. And there's a couple of articles that are sort of interesting that say that the use of these scales actually may increase suicide attempts because it gives people a false sense of security. So in England, there's a movement to stop using these scales. I'm not suggesting we do that now, but that is, it's part of something. It's not a continued thing. What it should include is that, and then all the things we talked about. Looking at the patient, finding their past history, their family history, talking to others, and then talking to the patient. Not just you have, our residents, and I imagine residents here, but positive SI, that meaning suicide ideation. What does that mean? It means positive. You don't have a clue what that means, so that's not the end of an evaluation. That's the beginning. So the APA put out suicide guidelines a couple of years ago and says the estimation of the risk at the culmination of an assessment is the quintessential clinical judgment, since no study has identified one specific risk factor or set of risk factors predictive of suicide. So there are some people who say, okay, you do the suicide risk assessment, and that should lead to sort of more of a formulation, almost like a psychodynamic formulation, where you take all the information and put it together. And this integrates how the factors, both the risk factors, the protective factors, come to yield some kind of a understanding. And we always use the word, low, minimal, high, and the high should get hospitalized, the minimal not. When people have looked at that, looked at studies that have categorized people low, medium, and high, and then looked at actual completed suicide, this last bullet, which is just published a couple of months ago, to date, suicide prediction models accurately produce accurate overall classification. So you could put people in these categories, but their accuracy in predicting future suicide is zero. Is zero. So it's just last month. Okay, so what should we do? For those of you who are in this kind of either an emergency room or an outpatient clinic, so you do a good history. You do what you know you're supposed to do. You talk to the patient, you talk to their family, you look at their records if you have. Assess past behavior, including the magnitude of the past behavior, because major attempts in the past can predict better than milder attempts. Family history, current psychosocial situations, assess hopelessness, and be very aware of shame and guilt. That's what the gentleman on there said. So patients may not share this with you. I tell my residents, we have a very busy ER, which all you guys, some of you have been in. We see 5,500 people a year through that ER. People come in, we have to move them out. So residents will go in and see somebody who's brought in, and within 30 seconds are saying, so are you suicidal? Now, who in this audience would share that with a stranger in 30 seconds? You just don't do that. But that's what systems are forcing people to do. So to the best of your ability, establish some kind of therapeutic rapport, which is hard when somebody's in restraints, but you try to do some kind of therapeutic rapport, identify strengths and factors, and reassess at various time intervals. Suicide is not a yes-no thing over time. People change. And so reassessment is very important. And then ask directly about the suicide. It used to be thought if I gave this talk to a lay audience or something like it, people would say, well, you don't want to ask if somebody's suicide because you'll put the idea in their head, which is actually a fairly well-held myth in the community. Okay, but you got to ask, not only are you having thoughts, but what are you thinking about? How frequently are you thinking about? What's the plan? Who knows about it? What have you done? Have you given away this? Have you given away that? Have you changed this? All these things can indicate more of an immediate risk. And not everybody who either makes a self-harming behavior is suicidal. So there's a different level of suicide or self-destructive behaviors. So there's suicidal thoughts, which is the wish to truly kill oneself, morbid ruminations about, I wish I were dead, I wish I don't wake up in the morning, but I'm not going to do anything to cause that to happen. And then there's self-harm, where people have no intent to kill themselves, but do have an attempt to hurt themselves. So I'm going to go over this briefly because I know time is getting short. There's a really interesting study in the Journal of Affective Disorders a couple of years ago where they looked at people who made serious self-harm behavior, serious enough to cause so that they would be hospitalized medically or psychiatrically. And then they looked at and sort of asked them what were the reasons for that. And there were very, very different reasons. And you can imagine if you think of everybody doing it for the same reason, look at the richness that you're going to lose. So what we typically think about, particularly with people with more severe personality disorders, is managing affect or dysregulation. And that's what DBT is all about. So people would say, I did it to calm myself down. I wanted to feel this pain to calm myself down. Other people did it as a communication. I wanted to see if anybody cared about me. Some people did it as punishment. I deserved to feel the pain. Dissociation, I wanted to stop myself from feeling this way. Sensation, I wanted to seek some excitement. Averting suicide, I did this so I wouldn't kill myself. I found it comforting. It made me warm. So you could read this, and again, it's in just a couple of years ago. It's a really interesting article. So again, you could see that if you don't talk to people about it and ask about what they're really thinking about, what led to it, you're going to miss all of this. And your ability to intervene specifically for that patient is going to be lost. None of this is easy. This ain't easy. My ex-chairman, a wonderful man, had it on his license plate, it ain't easy. About life and about this. So lots of people meet these standards, and luckily, the vast majority of people don't kill themselves. Think about countertransference. Again, we see in our ER, residents are up all night, they're busy, somebody's come in with the third suicide attempt of the month. And their countertransference can easily get in the way of that. And then patients may deny suicidal ideation for a host of reasons. Shame, cultural, they think it's a sin, religiously, feeling that nobody could help, wanting to hide it because they know if they say it, yes, then they may be hospitalized. So that's not so easy either. Many of you know Kay Jamison in the audience. Some of you have read her book. Psychologist here who founded the Mood Clinic with Michael. If I can't feel, if I can't move, if I can't think, and I don't care, what conceivable point is there in living? And Glenn Gabbard, who may be one of the best teachers of psychodynamic psychotherapy in the country, wrote, treatment of the suicidal patient may be likened to negotiating the perils of a minefield. With each step, one is terrifyingly aware of the potential lethality underfoot. So now I want to talk a little bit about trying to understand suicide. And one of the best formulations occurred by Ed Schneidman, who was here in Los Angeles. Was he a teacher of yours, Michael and Andy? He, along with Norman Faberell, founded the LA Suicide Prevention Clinic, was that what it's called? Which is the first such place in the country, written extensively about it. And he talked about suicide as not a movement toward something. It's a movement away from something. And it's away from unbearable pain, unbearable anguish. And talked about that there's a constriction of thinking. And the thinking goes, I either continue to feel as horrible as I feel now, or I kill myself. Nothing in between. Okay? So that's one very, very powerful way. The other one, and it's interesting because the man on the tape used the word belongingness. I felt I didn't belong. It was Joyner who writes extensively about it. And he talks about two other things. One is a feeling of perceived burdensomeness. I am a burden to, he said, I thought I was a burden to everybody around me. Okay? And a feeling of low belongingness. So these are the reasons, and then it was summed up in this in a textbook as the 3 I's. I can't stand it. It will never end. I cannot get away. Okay? So if you think about that, then it has some help in trying to understand what an intervention might look like. So then this was another study, and I'm going to do this real quickly. I'm sorry I'm going so fast. This looked at very serious suicide attempts versus moderate suicide attempts, in an attempt to see, is there something about people who come very close to killing themselves versus people who make attempts but not. And they looked at the dimensions that we typically think about, psychopathology and mental pain, interpersonal relationships, whatever. And what they found that the things that differentiated these two groups of suicides, not suicide versus non-suicide, but suicide versus serious versus less serious, were interpersonal relationship ruptures were more prevalent and more serious in those where there was serious suicide. And decision-making capability, not understanding, it's not really the risk-benefit, but the outcome of your decision. And it caused them to do this model where basically, for most suicides, there's psychopathology. For most suicide attempts, there's mental pain, negative events that leads to suicidal behavior. But what leads to more severe suicide behavior, and maybe completed suicide, but it's harder to study that, is the added burden of interpersonal relationship rupture and poor decision making. Now this is a model, it's not a validated model, but as early as the 1700s, Voltaire wrote this, which is exactly true. The man who in a fit of melancholy kills himself would have wished to live had he waited a week. Okay, so that outlines the task that we have. So the task we have in treating people who are suicide is the short term, how do we do that, and then what's the intermediate term. So the immediate goals are to establish a therapeutic alliance, and then what I like to think about is the third bullet, and I call it introducing the grays. Okay? So if you think of Schneidman's thing, I either continue to feel how horrible I am, or I die. There's a lot in between that, and that's our job. And our job is to say, let's look at what is in the middle of that. I'm not, again, saying, look, you want to kill yourself, you could kill yourself anytime. You can kill yourself today. You could choose to kill yourself next week, a month. But let's look at right now. and let's see what we could do right now. And if it doesn't work, you always have that option. But if you act on it now, there are no options. So you try to do that. You consider environmental manipulations. You take away all firearms. You include the family who may watch the person, take away knives, take away pills, et cetera, et cetera. Reduce access to lethal means. As I said earlier, if you got it there, you might use it. Countries that actually, I told you about firearms. In China, in rural China, the preferred method of killing oneself for young women was using pesticides, really gruesome death. When those were outlawed in certain provinces, the suicide rate decreased. I mean, this is not rocket science. This is taking away the method that is immediately at hand and making people do more steps to do it, as opposed to having it right there. What else can you do in the short term is, I don't know if Randy's here. Randall? Ketamine, okay? You've all heard about ketamine, and ketamine is a treatment for depression. Maybe it works, maybe it doesn't, maybe it's good, maybe it's bad. But there's a couple of studies that have shown that ketamine in the very short term can reduce suicidal ideation. And there's a number of actually pretty good studies. The effect may not last more than a day or two, but that may be the time that you need to do something else. So ketamine is a possibility there. Another theoretical thing is something called implicit cognitions. This is a research tool. The idea, there's a test called the implicit association test, which measures the quickness with which you respond to certain words that are on a computer. And there are tests that have implicit cognitions about race or ethnicity. But this is about death and suicide. The idea being that people who have suicidal thinking and thinking about death will respond differently than people who don't. And it may be a way of identifying people. It's been used in a couple of research studies. Most have been positive, some have not been positive. But it's something that people are looking at, and there's some money involved in that. Something called safety planning intervention. Talking with people, making a safety plan, which includes who you're going to call, when you're going to call them, what can you do to self-calm, how are you going to reduce lethal means, et cetera, et cetera. This was done at VA sites, 9 sites, over 1,600 patients. They did this intervention, and they did 2 follow-up calls following an ER visit. The suicide behavior, it wasn't completed suicide because they had very few of them, but suicide behavior decreased 45% in the group that had this intervention at the VA. And this may be rolled out more in VA settings as it goes on. Suicide contracts, we don't use them. You'll see on inpatient, if you read, patient contracted for safety, fine. That doesn't exactly mean what, that you're going to, it's not a legal document. If anything, it gives, again, a false sense of security. But this is very different than saying, we're going to make a safety plan, and I want you to commit to a safety plan. I'm not saying those don't work. I'm saying just tell me you're not going to kill yourself. Yes. Whew, boy, do I feel better. Okay? And there are, for the longer term, evidence-based psychotherapies. Jonas Sarno has one very well established for teens. Harbor was a site when she looked at teens coming into our emergency room. So Joan, there's different kinds of cognitive therapy, some specific for suicide. DBT clearly decreases self-harming behavior. Whether it decreases suicide itself is not entirely clear, as that's not entirely clear for any of these. There's problem-solving therapy, psychodynamic therapy, mentalization, et cetera. Pharmacology, not much. Large-scale populations, the 2 drugs that seem to decrease suicide in large groups are lithium for bipolar patients, which is interesting since we don't use it as much as we use virtually everything else. But lithium, there's a pretty good database for lithium. And for people with chronic psychotic disorders, clozapine has been shown to decrease that. In the short term, anxiolytics may be very helpful. There's a lot of data that anxiety disorders fuels depression and adds to suicide behavior. So if you need to calm somebody down in the short run, you might think about using a benzo. There's literature on that. There's less and using something like Seroquel or one of the more sedating newer agents, I imagine it's the same thing, just to break the cycle. Clearly, ECT for those people who have failed everything else. Okay, so I am done. I'm sorry it went longer than Jenna told me I was supposed to go, but I have time for questions now.
Thank you very much, Ira. Terrific talk. We have time for just a couple of questions. Yes.
The three I's. It'll never end. Let me pull it up so I will tell you exactly. Intolerable. It'll never end. I'm sorry. All right, let me look at it while we ask another question.
Okay. One more here. Yes, way in the back.
I'm not real familiar with that, so please talk about it a little bit, if you'd like.
It was longitudinal RCT, I believe, and they had teenagers identify a group of adults in their life that was important, and that group, I think, collaborated in some way and increased the suicide rate, complete suicide rate, and I would guess attempts, I think 10 years later. That's my...
So the notion of community and having a, yeah, I'm not familiar with that, but it would not be a surprise. I mean, that's, and again, part of the, we didn't talk about the young people, but part of the thought about, the increase in suicide in young people is sort of a lack of that. It's bullying and there's social media and shaming, and maybe not the same kind of community or family ties that there might have been, and trying to strengthen that. That would be, that would clearly be a reason to try and do that, but the data for that I'm not sure about. Thank you. Yeah.
Thanks for a very, very good talk. I have a question about the issue with the TV series that is so much a controversial
right. 13
issue.
Reasons Why?
Yes,
Yeah.
and what your thoughts are about how parents and others deal with this.
Yeah, okay. So everybody knows about that. There's a TV series that is now in its second season, as if the first season of it wasn't enough, about a teenager who kills herself, and then there's a number of episodes, each episode about part of that. And when that happened, the rate of suicide attempts and completed suicides in adolescents increased. We saw it in our own small adolescent ER, and it increased. There was a furor about that, and supposedly I haven't seen any of them, to be honest, just in point of truth in advertising. But the second season now supposedly has warnings, it has numbers to call, whatever. I think it's a real problem, that kind of contagion effect, if a young person who's seeing it on his or her own and has already been shamed and stuff. I mean, we know about contagion suicides. There's been a spate of contagion suicides up in the Stanford area, in Palo Alto area. And I think this contributes to that. That's different than saying that this shouldn't be talked about with young people, but it was almost, not really glorifying, but it was in that ballpark, which I think is very distressing. And I don't think that people quite understood that this was what the outcome would be. And then when it was, why they would do it again, other than other reasons.
One more question here before we have to break.
I was just wondering if you could put up the final conclusion slide again.
Sure. Okay, well, thank you all.